So my name is Jacob White. I will be presenting on a Jones fracture. So a little bit of background. The patient is a 21-year-old male collegiate soccer player. He sustained a Jones fracture while at practice and did not come into the clinic until after practice for evaluation. This is due to the injury occurring within the last 15 minutes of practice. The patient opted for non-operative treatment because he wanted to avoid surgery as much as possible. So, case presentation. The patient had two main goals. First were avoid surgery. Second was play soccer back home over the summer break. These were pretty much 1A and 1B. So, like I stated earlier, the injury occurred at practice. It was towards the end of practice. The patient was trying to make a lateral cut and misstepped, causing his ankle and foot to invert. He did not feel a crack or pop acutely, just pain. So the physical exam revealed minimal swelling around the base of the fifth metatarsal and inferior to the lateral malleolus, but again, it was very minor. Pain was a 7 out of 10 with activity, such as walking, and 4 out of 10 at rest. The evaluation revealed he could weight bear, but it was very painful, and he demonstrated an antalgic gait with a shortened stance phase on affected side. From here, he was referred for imaging. He was given a short foot and ankle boot to immobilize, as well as crutches for non-weight bearing. Re-imaging was to be done in 4 weeks. So his rehab and treatment was to maintain his physical fitness. Again, the patient wanted to avoid surgery and was very compliant with non-weight bearing and all restrictions. Modifications were made, so during lift, he performed seated upper body exercises, abiding by patient goals of avoiding surgery and continuing to play soccer when home. Rehab was focused on core exercises, open chain exercises on affected limb, and closed chain strengthening and proprioceptive training on unaffected limb. Rehab was focused on helping maintain physical fitness and prevent similar injury from occurring in the future. The patient appeared to be making progress and was anxious to re-image, so he could send images to coaches and doctors back home. He was re-imaged at 3 weeks instead of 4. However, the images showed a more apparent fracture line than initially, despite the patient's adherence to rehab and treatment. From here, the patient was again referred to physician for next steps, which I was not a part of due to clinical ending before the case was resolved. However, they did discuss surgery as well as continuing with conservative treatment. So, conclusion, Jones fractures do have a high chance of non-union due to poor blood supply as well as the muscular attachments at that point. They can be healed conservatively, but have the potential to take longer due to, again, the poor blood supply, muscular attachments, and have a higher risk of improper healing, such as non-union. Surgical fixation is recommended for best treatment, but in our case, due to the patient's goal of wanting to avoid surgery, conservative treatment was the initial route taken and was the primary focus for our rehab and treatment sessions. So again, that included immobilization and non-weight bearing. So the clinical bottom line. It is very important to discuss all outcomes with patients, both surgical and conservative. Just letting them know that surgical intervention is the recommended treatment. It is highly recommended and the best course of action when there is 3 to 4 millimeters of separation or greater than 10 degrees of plantar angulation. Patients can be managed non-operatively, but will require at minimum 8 weeks of immobilization and weight bearing, which is a significant amount of time to be non-weight bearing and immobilized. this is something that you want to bring up with with your patient and make sure that they understand that if they decide to go with a non-operative treatment, it will be an extended period of time. And so it is important to discuss the potential for non-union and other complications with the patient and ensure they fully understand what is to come in their treatment. Whether, again, that's being non-weight bearing for a significant amount of time, whether that's getting surgery and going from there, or just what are they going to do in their exercise and treatment program. So, again, just to conclude, discuss with your patients all possibilities, surgical and conservative, and what it takes to get surgery. That's going to be a pin, as well as the 3 to 4 millimeters of separation and 10 degrees of plantar angulation. All right, references. Thank you for watching.